Breakfast with WACh. Today, we're super excited to have our visiting speaker, Dr. Dickens Onyango, and Dr. Sylvia LaCourse will be introducing him properly, so I will leave that to you, Sylvia. But again, I'm glad so many people are there and online, and I'm really looking forward to hearing this presentation. So I'll pass it over to you, Sylvia.
Great, thanks, Grace. And I also wanted to, there are some familiar faces in this room, but we also have some esteemed colleagues and guests who are here today. And so Dr. Sybille is here today from Zambia. I'm not sure if you just want to provide an introduction, say who you are.
Good morning, everyone. Yeah, I'm Sybille from Zambia. I'm an infectious disease physician. Specialized with interest in HIV, that's what I do, and a bit of TB. I am the lead for HIV treatment at the Ministry of Health. I'm doing that for the last 5-6 years. Yeah, so I do quite a lot of administrative work. I'm involved with research as well. Yeah, so we've been running a few clinical trials which we'll share in there. So I'm happy to be here. I was invited by Adrian. I think we were working together on the Datura study where they were overseeing as DSMB. So pleasure to be in Seattle. Thank you.
Dr. Sybille will be presenting today as part of the CFAR series, and Dr. Onyango will also be presenting as a new faces speaker for CFAR. So a lot of excellent connections. So now I'll focus on, it's really a pleasure for me to talk about Dr. Onyango a little bit. So, and I have some cheat sheet here because he has so many accolades, I don't want to miss anything. And so I've had the pleasure of working with Dr. Dickens Onyango for a while now. He's a physician and a public health researcher. He's the Deputy Director of Medical Services in Kisumu County in Kenya, and additionally a visiting scientist at Kenyatta National Hospital. He earned his medical degree at the University of Nairobi, his Master's of Science in Epidemiology through the CDC-sponsored Kenya Field Epidemiology Training Program, and a PhD in Epidemiology from Utrecht University. And in 2020, I had the pleasure of working with him as well as with Grace John-Stewart and John Kinuthia for his Fogarty Global Health Fellowship. I'm really impressed with Dr. Onyango. He wears many hats, including both programmatic leadership and then also able to really pivot and think about the role of cutting edge technology. We'll hear a little bit about that for the with neurodevelopment. Other roles he's played the site PI for the CHAMP study, which evaluated causes of preventable death in children under 5. We talked about the role of innovative use of MRI to evaluate infant neurodevelopment. And then really where my heart lies is also in evaluating implementation of TB prevention and some cool novel urine testing for adherence using a test developed by the Lutz lab at UW Bioengineering. He successfully received grants from the Furlan Foundation and is a CFAR mentored international investigator. And we'll hear more today. He recently put in a K application, which will be under review this month. So without further ado, Dr. Onyango, thank you for joining us today.
Thank you very much, Sylvia. Thank you very much, everyone, for inviting me to come and present to give this talk. I'm going to talk about some of the work we have done in Western Kenya, particularly focusing on causes of death, the neurodevelopment, and TB preventive therapy work, which has been graciously mentored by Dr. Sylvia LaCourse and Dr. Grace John-Stewart. Yeah, so I will start with the work that we've done with CHAMPS. CHAMPS is an acronym which stands for the Child Health Mortality Prevention Surveillance, which is a Bill and Melinda Gates Foundation-funded initiative to be able to track the definitive causes of mortality among children under the age of 5 years, and to disseminate high-quality data to inform policy and public health action. And this CHAMPS is currently being conducted in 8 sites across the world. So some of the sites are presented there. There are some newer sites such as Nigeria, which is not reflected in that map. But in Kenya, CHAMS is conducted in SAIA and Kisumu County, where I am. I'm one of the co-site directors for the Kenya CHAMS site. So CHAMS in Kenya, we have two health and demographic surveillance sites. One of them is urban within Kisumu County. Kisumu is the third largest city in Kenya. And within Kisumu, we have Manyatta, which is an informal settlement, which is the very first map there showing the health and demographic surveillance site with an under 5 population of roughly 22,000. Kisumu, both here and Kisumu is a region with high HIV prevalence. In Kisumu, 17.5%, and SAIA around 15%. And routine mortality surveillance is conducted in both for community deaths and health facility deaths in the community by the administrators such as chiefs and their assistants, but in the health facility by health providers. But then CHAMS brought in this mortality surveillance system, which then relies on various stakeholders, including village reporters, community health volunteers, religious leaders, to be able to notify the deaths. So CHAMS really depends on 3 pieces of work. One is the mortality surveillance. So for the mortality surveillance, we track the children who die with age under 5 years, including stillbirths, within the health and demographic surveillance systems. Once a death is detected, then they are evaluated for their eligibility to be enrolled in CHAMS. And once they are enrolled, then there are 3 main procedures that are conducted. One of them is a verbal autopsy, which is conducted within 4 weeks after death. And for those who qualify for a minimally invasive tissue sampling, the MIIA. So the MIIA postmortem is conducted for deaths that occur within 24 hours, are notified within 24 hours. And for deaths that are then notified outside that period, they could still be enrolled in CHAMS, but they can be enrolled in CHAMS as non-MIIA cases where you only do a verbal autopsy, then you abstract clinical information. The third procedure is then the abstraction of clinical information. And this is from the records of those who die within the facilities, then the records in the facilities. But for the ones that die in the community, then that abstraction is very limited. And for the for stillbirths and neonatal deaths and the infants, we also abstract maternal records. So my slide there shows some of the tissues that are sampled during MIIA. One of them is the brain, the lung, the heart, the liver, the bone marrow, the blood, CSF, stool, and NP and OP swab. And once these samples are picked, they are taken to the lab for pathology, for culture, and then there is this testing using the Tuckman array cards, which test for an array of pathogens. HIV, TB, malaria testing being done using the usual methods that are used programmatically. So the determination of cause of death is conducted by a panel of experts, which is about 5 or 6 experts, including epidemiologists, pediatricians, pathologists, and they assign causes of death based on the WHO death certificate, which is 3-tier. That is, it has the immediate cause of death being the event that immediately precedes death. You have intervening causes of death. Then you have the underlying cause of death being defined as the disease or injury that initiated the train of events that directly led to that. So when CHAMS determines causes of death, they focus on the causal chain, looking for the underlying, intervening, and immediate causes of death. That's for infants and children. For the stillbirths and neonates, they apply the ICD-PM death certification, which focuses on a main fetal condition and a main maternal condition. So that's the difference between the way causes of death are determined for those two categories. So I'm going to present some results up to end of last year. By the end of last year, there had been over 2,000 notifications from the Kenyan side. Of this, 28% of the deaths had occurred in the community, while 72% had occurred in the health facilities. And the main sources of these notifications are community health workers, abbreviated as CHWs in that slide, and then the health facilities as the main notifiers. So in terms of the CHAMS cascade, so far, and I've skipped a couple because we start with then the notification from notification screening for eligibility, and then once somebody is eligible, then they could give consent to be enrolled in CHAMS, and once they are enrolled, they are further then consented to for MIIA. So the consenting for MIIA is independent of enrollment in CHAMS. But so far, there have been 1,556 deaths that have been enrolled in CHAMS. Of those, 99% were MIIA eligible. That means that they came within 24 hours of death. And of the ones that are MIIA eligible, 88% have had MIIA successfully conducted. That drop-off majorly is because of consenting, and sometimes during the consenting period and the logistics for performing the postmortem, things don't go right, and then some cases don't get performed autopsy. But of the ones that have had autopsy, 92% have been decoded, meaning that their causes of death have been determined. And that pie chart just shows us the age distribution of those who have been decoded in the Kenya side. 42% of them being children aged at least 1 month to under 4 years, or to 54 to 1 month to 59 months. And then the neonates, 29%, and the stillbirths, 29%. So I'm going to just start by presenting some causes of death that have emerged over the last couple of years from the Kenyan side. And for this one is for the stillbirths. For the stillbirths, the overwhelming majority of them, the cause of death that has been determined is perinatal hypoxia. So that includes, if you look at the ICD coding, that includes 2 points. So one, it's intrauterine hypoxia, first noticed during pregnancy, and then during labor and delivery. So also that covers as well birth asphyxia. So 98% of these stillbirths have only one cause of death. So if you remember, when we determine cause of death for stillbirths, you go for the main fetal, and then there are other fetal. So meaning that 98% of them, they just have the main fetal condition that is judged to have caused the death. So the other one is, this slide shows the causes of death for neonates. So for the neonates, again, perinatal hypoxia, that is asphyxia, hypoxia causing 33%. And then sepsis coming in second, and preterm birth complications coming in third. And there is also pneumonia and congenital malformations and aspiration pneumonia. And in this case, among the neonates, about 4% of them have multiple causes of death. That means they would have, a main fetal, and then a couple of other fetal conditions that are in the causal chain. So then we now turn our attention to the infants and children. And here the usual suspects, malnutrition being the leading underlying cause of death, followed by malaria. Both Kisumu and SAIA are malaria endemic areas, and followed by HIV, and then gastroenteritis. HIV and gastroenteritis are tying at number 3, and pneumonia, sepsis coming in closely. There are also others with congenital birth defects, sickle cell, aspiration pneumonia. Again, sickle cell due to the high prevalence of malaria in this region. This region has a high sickle cell burden. So 60% of these children aged infants and children, they have multiple causes of death in the causal chain. And so very quickly, I just have a slide here that shows some of the organisms that have been shown to cause sepsis when they have occurred in the causal chain for stillbirths and for neonatal deaths. And Klebsiella pneumonia, E. coli, they seem to be the leading pathogens that have been detected, and then also group B strep causing that. I think that in itself looks very different from, let's say, like the antibiotic treatment regimens that are, routinely recommended by the programs in terms of targeting first line targeting more of gram-positive bacteria. But again, this may be the select group of children who died. We don't know if the same organisms would be, causing morbidity among the children that did not die. So there are actually some discussions about, whether this data that comes out of CHAMPS is representative enough to be able to inform changes in guidelines, let's say, for selection of antibiotics. Again, if you look at sepsis, and this now combines sepsis and pneumonia for infant deaths and children, Klebsiella pneumonia, E. coli, and strep pneumonia being the top 3 pathogens, but you can also see some viral causes coming in there, cytomegalovirus, adenovirus. And still, if you look at it, similar picture to what we was, almost similar to what we were seeing in the younger age groups. And therefore, one thing that has been noticed then that Klebsiella pneumonia seems to be quite a pathogen now that is seen to be causing either these deaths, but again, during the same period that this story started emerging in Kenya, I think there were also these reports of Klebsiella kind of outbreaks amongst in the NBUs and in some of the major hospitals. So it probably reflects what's happening. And then again, when you analyze some of the deaths by the place where they occurred, you realize that the Klebsiella pneumonia and E. coli deaths still are found even among children that died in the community without interaction with the health system, probably indicating that some of this is actually community acquired. So one of the questions that the DCOD panelists are usually asked after they have determined a cause of death for each child is whether the death was preventable. And in the Kenya site, over 90% of the deaths are judged to be preventable. And they are then asked to identify where the gaps were, and then they come up with the recommendation. So the bar chart there shows the recommendation, but this is framed as recommendations, but you can also look at it as the gap. So if you look at the quality of care being one of the leading causes, or non-medical, if you look at the WHO 3 delays framework, then they are also referred to as non-medical causes of death. And then the health-seeking behavior also coming in second. So health-seeking behavior is more of the first delay, and the quality of care is more of a third delay. Those are delays within the health system. So if you look at the contributing factors to deaths, then those 2 delays seem to be leading contributors of mortality. And though if you look at one of the objectives of CHAMPS was to then find a way of translating the data that comes out of CHAMPS into more public health action, I think this is not as well developed because there's a lot more of investment in generating, doing the postmortems and generating the data. There is still a lot of opportunity to be able to look into what are the public health actions that would then come out of some of these findings that come from CHAMS. And if you look at the health system, there are, whenever you do these postmortems, then there is always that story behind the death as to what occurred. And there are a lot of those health system gaps that come out of these stories. And, there's a challenge about, yes, if there are all these inadequate resources, inadequate skills, or these delays in the health system, then what do you do with it? How do you then come up with interventions that then would help to be able to improve child survival? So I think I'll pause there for CHAMS, and I turn over into another story of neuroimaging. And in Kisumu, part of the CHAMS site, when the Gates Foundation was coming up with a new initiative called Pregnancy Risk Measurement Alliance, PRISMA, then they included the CHAMS site in Kenya as one of the sites for PRISMA, which PRISMA has ended up having other sub-studies that are nested within it. And one of them is called REMAP, which is redefining maternal anemia in pregnancy and postpartum. And then this REMAP, you now have the REMIND. I think many of you are familiar with the MIND study. In fact, this one was also temporarily called MIND before it was realized that there's another mind. So they introduced RE to be able to differentiate it from the other mind. So REMAP, so the RE is for REMAP, measuring infant neurodevelopment with portable low-field MRI. And we have a site in Kisumu. So this particular one is nested within a cohort of women who are participating in the REMAP study, the one that is really looking at anemia in pregnancy. And this has two cohorts, three objectives. So objective one is to have this healthy cohort of pregnant women whose hemoglobin measurements can be used to define the reference values for normal hemoglobin, And then we have this other objective that is dealing with the etiology of anemia, the women with anemia. Then there are this number of measurements that are conducted, including micronutrients, to look at what are the contributing factors for maternal anemia. And it is from this sample that we have a subset of the children, about 150 to 300 per site, that are targeted for evaluation of neurodevelopment. And the main objectives of this is really to assess the impact of maternal anemia on infant neurodevelopment, and particularly focusing on brain volume. And so the REMIND study targets to enroll about 150 to 300 mother-infant dads per site. So for our site, that's going to be our target. And we do brain imaging using the low-field MRI. So the low-field MRI is there in the picture. It's supposed to be a portable MRI that can, move around. But in many sites, including ours, it's put in a room where the mothers come and their children get scanned. So we scan the infants at 3 time points. That's at 3 months and then 12 months to just look at the changes in brain structure and volume. And there is also psychometric assessments for neurodevelopment using the global scale for early development, the GSED tool, both the short form and the long form. These are WHO tools that are currently under validation. And this slide simply summarizes the story of the scanning, that the scanning protocol lasts roughly 30 minutes. And each of them, like the brain volume, the first 15 minutes, the T2 relaxometry around some few minutes, and then magnetization, transfer imaging, another 7 minutes. And so the scanning should take around 30 minutes, but the entire scanning and preparing of the patient takes 45 minutes. A minimum of 3 orientations of T sequences are needed, T2 sequences are needed to have a successful scan, as shown there, as sagittal, coronal, and axial T2 images. So in Kisumu, we have done now over 280, I think this is as of January, was 274. And of the attempted scans, 99% have been successful. And of the ones that have been successful, 85% of them have usable T2 scans. A lot of the scans are normal, but then the analysis of it is some part that is still pending. So I will not have any results to show for how, the results of the MRI measurements, but it suffices to say that this is some exciting piece of work that's being conducted, and it's an opportunity to be able to explore further. And so I'll now turn into what I did for my Fogarty project, which is to assess the tuberculosis preventive therapy among children living with HIV. This work has been published previously in Journal of International AIDS Society and AIDS. Children living with HIV are 8 times more likely to develop TB if they are infected with Mycobacterium tuberculosis. IPT reduces that risk by up to 60%, but this requires consistent adherence and completion. At the time we were doing this, there was limited data about IPT cascade performance in children living with HIV, especially from very high burden settings, and biomarker assessment of adherence had not been done. And previous studies showing that self-reported or caregiver-reported adherence is actually unreliable. And we performed this study in a network of facilities, about 7 high-volume HIV clinics in Kisumu, where HIV prevalence is 17.5%. And we had both a retrospective and prospective component. For the retrospective, we abstracted data from children who are enrolled in HIV care from August 2015 to July 2019. We did abstraction from medical registers for about 1,000 clans. And for the prospective cohort, we enrolled 100 children living with HIV, aged less than 15 years on IPT, assessed adherence monthly through pill counts, but also caregiver reports. And for the older children, the self-reported adherence. And then we also collected urine for biomarker testing. So we used 2 biomarkers. We used the IsoScreen, which is the commercially available one at the bottom of the screen there, and then a urine dipstick test that has been developed by the Luz Lab here at the University of Washington. And so part of it, we were validating the Luz Lab developed dipstick test. So we defined self-reported adherence as a report of consumption of at least 80% of pills, with the last pill taken within 48 hours of the visit. And the biomarker was positive. Biomarker adherence was positive on IsoScreen or dipstick at all time points assessed. So this was really our definition of consistent adherence. And then we assessed sensitivity, specificity of the dipstick compared to the IsoScreen, and assessed correlates of non-initiation, inconsistent adherence, and non-completion using generalized linear models. And also for the biomarker, we also assessed factors associated with positive tests using general estimating equations, but I'll not be able to show that. So for the retrospective cohort, we had these 856 records between August 2015 to July 2019, and 50% of these were aged 1 to 4 years, 54% females, and 79% in stage 1 or 2 WHOH category, WHO staging. For the cascade, when we evaluated it, 78% of children who initiated IPT completed. So there were significant drop-offs at initiation and then at completion of TPT. And so those are some of the correlates of non-initiation and non-completion. So attending a high-volume clinic, being virally non-suppressed, and then year of enrollment from 2017 to 2019 was associated with both non-initiation and non-completion. And here we just share some of the biomarker results. We had 301 concurrent pill intake and biomarker assessments. And of these 301, 67% of the tests were positive. And the table there compares the performance of the dipstick test in comparison with isoscreen as gold standard, and sensitivity and specificity for isoscreen for the dipstick test developed by the University of Nairobi of the UW was 98% and 95% respectively. So looking at adherence in terms of biomarker confirmed adherence for all time points assessed, that means if you had 6 tests, then we would expect you to have 6 positive tests for you to be classified to have biomarker confirmed adherence. So by isoscreen, 35% had consistent biomarker adherence, and then by dipstick, 36%. But then when you looked at either of them being positive at all time points, it was 39%. So this is the proportion that we judged to have consistent biomarker confirmed adherence. But when we assessed through the history of pill intake, 59% had reported consistent adherence. So you can see that there was that discrepancy. In terms of the correlates for non-adherence to IPT, maternal age, child age less than 5 years, and being virally non-suppressed was associated with inconsistent adherence to IPT. So some of this work looking at how adherence to IPT confirmed biomarkers was quite low in this cohort. And then we have also now had some other cohort of adults that are on 3HP that we have studied adherence in, and I'll be presenting that later. And looking at these challenges with adherence, this has inspired my K43 application, which Sylvia alluded to. And for my K43 application, I was thinking about 2 things. One, that now people are moving from the 6-month isoniazid to more shorter regimens. And then these shorter regimens are being self-administered, but they are being taken, let's say, once a week. For instance, the one that I'm really focusing on is the weekly 3HP, that then the previous approach to assessing adherence using the dipstick tests was to wait for them, they come to the facility, and then you do the urine testing. But that would work very well with regimens that you take very daily. But for regimens that you take weekly, then there might be challenges. If somebody says they come on Friday and they say the last time they took the pill was on Monday, and it's just all right to have taken it on Monday, then that brings in the dilemma of how then do you interpret your test. So my thought regarding the K43 then is, can we have then some kind of biomarker assessments for adherence at home or within the community, and then pairing this with some kind of adherence support intervention. So my M1 was to design as a community health worker delivered urine dipstick guided adherence counseling intervention. And then M2 is to evaluate this intervention using an individually randomized clinical trial comparing the urine guided adherence counseling to standard of care, and then assessing some of the implementation outcomes such as acceptability, feasibility, fidelity of the new intervention. So really that's my K43 application, and I hope that I'm keeping my fingers crossed that I will get some positive feedback on this. So in summary, we started with causes of death, and we've seen that majority of the causes of death in children are treatable and preventable conditions. And then there is this emerging evidence of gram-negative bacteria taking some prominence in causing these deaths. But all these medical causes of death then pair up with health system delays to be able to contribute to these deaths. So the innovations such as the low-field MRI provide this feasible and excellent opportunity to study neurodevelopment, and then looking at this suboptimal attack and completion of TB preventive therapy. This provides this opportunity for us to now explore community-based interventions for providing real-time information on adherence to TB. So I would like to acknowledge the Kenya Prisma Charm site, a D43 grant by PI Tom Horn, which has supported my visit here. The Luz Lab, which has done the urine dipstick test, and my mentors, especially Grace and Dr. LaCourse, who are here. Thank you very much, everyone, for listening to my talk.
Thank you for that excellent talk. We do have some time for questions, and so I'm wondering if there's any questions from people in the room or from folks online.